Hello and welcome. I'll give a few minutes for everyone to come into the webinar. Maybe not a few minutes, I'll give a minute or so. I see people, our participants are joining. All right, and welcome everyone to the Myositis Association's Empowerment Clinic on living with necrotizing autoimmune myopathy. My name is Rachel Bromley and I am TMA's Senior Manager of Education, Support, and Advocacy. And today we have the honor of speaking with Dr. Andrew Mammen. After obtaining his MD and PhD at Johns Hopkins, Dr. Mammen completed his neurology residency and neuromuscular fellowship at the same institution. He co-founded the Johns Hopkins Myositis Center in 2007. He and his colleagues discovered a novel form of autoimmune myopathy associated with statin use and autoantibodies recognizing HMG-CoA reductase, the pharmacologic target of statins. In 2014, Dr. Mammen moved to the National Institute of Health, where he is an investigator and leader of the Muscle Disease Unit. In addition to seeing myositis patients at the NIH Clinical Center, he maintains an appointment as adjunct professor of neurology and medicine at Hopkins, where he continues to see patients at the Myositis Center. Dr. Mammen, thank you for being here. We also have joining us Colleen Layton. Colleen is a kidney and dialysis nurse who was diagnosed with necrotizing autoimmune myopathy 10 years ago. Colleen is a member of the TMA Patient and Family Advisory Council. She and her husband have 2 sons and live in New Jersey. Despite her disease, Colleen still engages in her hobby of horse riding and is excited to share how she adapted her hobby to her illness. Thank you for being here, Colleen.
Thank you for having me.
No problem. All right, well, first we're going to have a presentation from Dr. Mammen. If you have any questions, you can put them in the Q&A box at the bottom of your screen, not the chat box, please, but the Q&A box. And I will go ahead and replace Spotlight. There you go. Hi, Dr. Mammen. I hope we can hear you. No, we cannot hear you. Do you have any speakers or anything connected to your system? We can't hear anything you're saying. I'm going to go ahead and start the interview with Colleen while you get your audio visual stuff squared away.
Can you hear me now?
Oh, no, here we go. I can hear you now.
Great.
Great.
Is there a mechanism for me to be able to share my screen with you?
Yes, one moment. Okay, it says all panelists can share, so you're free to start sharing.
Okay, I don't seem to. Maybe we'll, do you want to go ahead and start with the other person? Because I do not seem to have a mechanism for sharing my screen, which is very unusual.
Okay, no problem.
Yeah.
All right, well, Colleen, what I'm going to do first is I am going to share your video.
Okay.
All right. that video always makes me,
I know, it always gets me right here because it's been
it's
been such a
just
dream.
too much. It is too much. I just can't, and that's the main reason that I wanted to have you on the show today, was to show people that life goes on after diagnosis. There is life after diagnosis. It may not look exactly like it looks before, and there's a new normal, of course. Some people like that phrase, new normal, and some people hate it, but the reality is that life doesn't look the same, but it's still, you can, like you said, find what makes your heart sing. And coming from me, that doesn't mean as much as coming from you. So talk a little bit about your journey. How did your diagnosis, how long did it take to get your
I
diagnosis?
was extremely fortunate. I was extremely fortunate in that, I'm not a thin girl, and I've never been a thin girl. So of course, in my 40s, it was kind of like, well, you're a little sedentary. You need more exercise. Try taking some weight off. That was like the initial blanket.
It is always,
process.
isn't it?
Oh, right,
Yeah. You come in for like something scraped on you got a cut,
Right.
and they're like, have you looked at how much you weigh?
Right.
They always do that to you.
And as a nurse, I just assumed, okay, I've done something to hurt my back. I've been in a career 10 years. I've done something to hurt my back. Let me start there and see if there's something going on with my back, because I just had weakness, maybe a slipped disc, something going up and down steps. I had very, very good luck to go to an orthopedic clinic with a high reputation for non-surgical outcomes, because I knew that I wanted to try and avoid surgery. And that doctor took one look at me and he said, I have plenty of bariatric patients and every one of them can comb their own hair. And you are 43 years old and this is not normal. And we're not going to stop until we find out what's wrong. And he ran a CK level. And the CK level at that time, I think, was 11,000. So in I went for, and I went into the hospital again, just had really good luck to connect with a good rheumatologist who said, let's get a muscle biopsy. And that diagnosis was polymyositis. And then my rheumatologist, in addition, ran an ANA panel. And we found out that I had the anti-SRP. And I started on azathioprine, and it worked really well for about 3 years. And then I failed that, and the symptoms kind of started happening again with the falls and the dysphagia. And at that point, they sent me down to Hopkins, where I saw Dr. Louie. And Dr. Louie changed my medication to Cellcept, and Cellcept has been my wonder drug. I think I'm probably stronger now than I was during the azathioprine period.
Wow. Well, you've raised some questions that we have received for this video. So I'll move over to Dr. Mammen and see how we're doing over there. Okay, did we have any luck? Now we're back to not being able to hear you.
There you go. Can you hear me now?
Yes. Yes.
Yep. So you'd think I'd be perfect at this after a couple of years, but I always find new things not to understand about Zoom. But I think I'm good to go. I have a little slide presentation if you want me to go ahead and show.
Yeah, that's great. Yeah.
So let me do that. I think I should now be able to share my screen. So just give me 1 second and I will do that.
Yep, we can see it.
Hopefully you can see this now. So I was just going to sort of give a broad overview of necrotizing myopathy. And Colleen, thanks for sharing your story. That was really inspirational. But, I just wanted at the outset, just make sure that everybody understands that we have a lot of different terms for the same family of diseases. And so there's no confusion, there's at least 4, if not more, sort of different ways of talking about necrotizing myositis. So these are all the same disease: necrotizing autoimmune myopathy, autoimmune necrotizing myopathy, immune-mediated necrotizing myopathy, and necrotizing myositis. They all have necrotizing in the name, but just I sometimes switch back and forth between these different terms.
Well, thank you so much, because that was my first question. It's very confusing, so thank you for clearing that up.
Yeah, so those are the at least 4 different names that we have for the same disease. And I just wanted to start we heard a little bit about your case, but I kind of wanted to start. This is sort of a typical case presentation for the type of patients that I see. This first guy was a 71-year-old guy who had a past history of high blood pressure, type 2 diabetes, and high cholesterol. And this guy had been on statin therapy, which I know you probably weren't, Colleen, but he had been on that for like 7 years. In December of one year, he developed a respiratory infection and developed muscle pain. And he was given some antibiotics. And while he was on the antibiotics, he started to develop more muscle pain and leg weakness. He was having trouble getting up out of chairs. He went to go see his primary care doctor because although his lung infection got better, he was noticing he was weaker. And this gentleman, when he showed up in February, had a CK that was over 2,000. And again, I think everybody on this call, if they have myositis or family members of myositis, have heard about the CK. But again, just to sort of reiterate what that is, CK is a protein that's normally inside your muscle cells. And we all have like a little muscle damage just from moving around, and a little bit of CK might leak out. In a lot of us, that means when you measure it, the level's like 200 or 300. But if the muscle fibers are breaking open for any reason, the CK leaks out of the muscle cell and goes into the blood where we measure it. So this CK of over 2,000 is probably 10 times higher than we would expect in somebody who doesn't have a muscle problem. Now, he had been on this family of medications called statins, which lower cholesterol. And it's well known, and it had been known for years, that statins can cause muscle damage. And so the first thought for this gentleman was, well, maybe the statin itself was causing the muscle damage. And so the statin was stopped. Now, we used to think when you stop the statin, the muscle damage should go away because it's the statin itself that's directly harming the muscle cells. And you let that wash out of the body and you should get better. But this guy, even 7 weeks after stopping his statin medication, kept getting worse. So it didn't appear that the statin itself was causing his weakness. And in fact, his CK, shot up to nearly 9,000 in just 7 weeks. And then by the time I saw him in April, he was in a wheelchair. So just from January to April, went from walking around normal to being not able to walk by himself. And many of you guys may have had the needle EMG test, and we did that with him, which showed that he had some kind of problem with his muscle, and he was quite weak when we saw him in clinic. And it was like his arms, like you said, you couldn't raise your arms above your head to comb your hair, that he was having the same problem, but even weaker in the legs, really could not really even get out of a chair and walk by himself. And so we did, like you had done, Colleen, a muscle biopsy. And I show you kind of what this looks like here. And I'm not going to go through like how to read a muscle biopsy, but I can tell you this is a very abnormal looking piece of muscle here on the left. And what we did not see was a bunch of inflammatory cells in the muscle biopsy. Which is what we see in most kinds of autoimmune muscle disease. Instead, what we saw was the muscle cells were dying and trying to regenerate. And when you do a muscle biopsy and you get that result, it can be a lot of different things. It's not necessarily an autoimmune disease. It could be because the patient has a cancer and the cancer is sort of indirectly causing muscle damage, or a patient could have a genetic muscle disease. Many of you might have heard of Duchenne muscular dystrophy, which affects kids, but there are other genetic muscle diseases which can affect adults that have muscle biopsies that look like this. Or you can have what we call a toxic myopathy, which means some medication like a statin is directly causing the damage. Or it can be an autoimmune process. And for this particular patient, we ruled out all the other things and determined it must be an autoimmune process. And so I wanted to just quickly review that, necrotizing myositis is one of several different types of myositis that we see. And without going into too much detail, I'll just tell you guys that there are 4 major kinds. Inclusion body myositis, which unfortunately we don't really have good treatments for. Dermatomyositis, where people get weak and also have characteristic skin rashes. And here's what those look like here. Those are, see if I can point to them. Here's my laser pointer. right? So here is what the eyes look like in somebody who has dermatomyositis. They get these rashes over their upper eyelids, and patients with dermatomyositis also get these rashes, which are over the joints in their fingers. So that's different from what our necrotizing myositis patients look like in general. There's something called the anti-synthetase syndrome, which I won't go into too much detail. And then there's necrotizing myositis, which is, what we're talking about today. But just to put it in context, necrotizing myositis is one of the 4 major types of myositis that we see. And there are really, among patients who have necrotizing myositis, there are 3 different types of myositis, and they're each probably different diseases. So Colleen, you have what we would call anti-SRP myopathy, because you have autoantibodies that recognize SRP, which is short for the signal recognition particle, which is a protein that's important for everybody. It's in every one of your cells. The second major type is anti-HMGCR myopathy, and patients with this have autoantibodies recognizing HMGCR, which stands for HMG-CoA reductase, which is the enzyme in every cell of your body that helps make cholesterol. And then there are people who have a necrotizing muscle biopsy, but don't have either of these 2 antibodies or any other autoantibody that we know, and we call these antibody negative necrotizing myositis patients. So, this talk is about necrotizing myositis, but important to recognize there's really 3 different types, and they're different. They probably have different causes and potentially different treatments. So it's important to understand that.
Dr. Mammen, are they different symptomatically?
So that's a great question, and I'll get to that right now. But what I would say is, in terms of the muscle involvement, you can't tell the difference. So if Colleen walked into my office and I saw her muscle biopsy, and that's all I knew, I wouldn't be able to tell you whether you've got anti-SRP or anti-HMGCR. You can tell by the antibodies and by some of the other features. So for example, patients with anti-SRP even though that case I just told you is pretty rapidly progressive, SRP tends to be pretty progressive. People can get weak really fast. And in fact, the younger you are when you get it, probably the faster that happens, which is kind of counterintuitive, because we think of older people as being maybe less resilient to autoimmune disease. And with other types of autoimmune disease, the older people do worse, but it's the opposite in HMGCR and SRP. The younger people actually do worse.
Dr. Mammen, I wanted to interject that somebody in our audience has NM, I don't know what phenotype, and they are 23 years old. And they are wondering how often you see patients of that age or any younger, or is she an anomaly? Or
not an anomaly. He's not an anomaly. And in fact, children can get this, right? So I'm really talking, I've been mostly talking about this as if it's an adult disease, but these diseases can affect the necrotizing myositis. All these 3 different forms can affect children and young adults as well. Although with anti-HMGCR myopathy, it's more adults and more older adults than children. And that's because one of the triggers is statins, and I'll get to that. But 2 things that distinguish anti-SRP myopathy from anti-HMGCR myopathy is some patients with anti-SRP have lung involvement, what we call interstitial lung disease, which can cause problems with breathing, essentially, and with oxygenation of the blood. And you'll find this in about 1 of 5 anti-SRP patients if you look for it. The good news is that it's usually mild and sometimes most of the time patients don't even notice it. But if we do like a CT scan of the chest, we can see that it's there sometimes. The other thing is the heart can be involved in patients with anti-SRP myopathy. We think it's maybe around 10 to 20% of patients who have anti-SRP myopathy don't just have skeletal muscle involvement, but also heart muscle involvement. And so that can be a significant issue for these patients. I mentioned that it's difficult to treat. And again, I would say It's usually more difficult in younger patients than older patients. For anti-HMGCR myopathy, one of the key important things about this, which many of you probably know who have this disease, is that it's very frequently associated with an exposure to cholesterol-lowering statin medications. So the most common one is atorvastatin, given to people who have risk factors for developing heart attack or stroke, which would be high cholesterol. And we think our best estimate is that if you give people statins, about 1 in 50,000 of them will develop anti-HMGCR myopathy, which is an autoimmune disease that takes on a life of its own. Even after you stop the statin, the myositis continues to progress. You can't just stop the drug that caused it. You actually have to treat the autoimmune disease with immunosuppression. Many of these patients have muscle pain as well as muscle weakness. If there's good news about this type of myositis, it's that it almost only affects the muscle, the skeletal muscle. So these patients don't get rashes, they don't get lung involvement, and they don't get heart involvement, the vast majority of them. However, if you give an anti-HMGCR patient a statin again, and sometimes we see this happens, people put them back on a statin medication, even if they were well controlled, that can cause the disease to flare up again. So patients with anti-HMGCR myopathy, they really need to stay away from statin medications. And then the third type is antibody negative necrotizing myositis. This is not as well understood as the anti-SRP and anti-HMGCR myositis. The things that I can tell you about it are that it really tends to affect more women than men, like a lot of other autoimmune diseases. And it often happens in patients who have some other autoimmune disease. So patients may have lupus or rheumatoid arthritis or Sjogren's syndrome. And then on top of one of those diseases, they develop antibody negative necrotizing myositis. And these patients, kind of like the SRP patients, but even more so, can develop problems with lungs and joints and things like that. So we've learned a lot about anti-HMGCR myopathy, and so the most common type of necrotizing myositis that we see is anti-HMGCR myositis. So I'm going to talk a little bit more in more detail about anti-HMGCR for a minute. The first is, we want to know, are there risk factors for developing it? And I already told you that that having a statin exposure is a risk factor, but another risk factor is type 2 diabetes. So you're at greater risk of getting this if you have type 2 diabetes and you get put on a statin medication, particularly atorvastatin, which is also known as Lipitor. So that's one thing. The other thing is that so in the United States, at least, both Black and white patients seem to be at equal risk for developing anti-HMGCR myopathy if they get put on a statin. Like I said, it's about 1 in 50,000. But we found that the Native American population, and particularly the Navajo and Apache, have a much higher risk of developing anti-HMGCR myopathy. So about 1 in 300 Navajo or Apache patients who get put on a statin will develop this, which is just huge. We think it means that they have probably some genetic risk factor that we haven't yet identified that makes them susceptible to getting this disease if they get put on a statin. And one of our research priorities is to find out what that risk factor is. And it may be important not just for the Navajo, but for also other patients who might be more at risk for developing this, because we'd love to be able to predict before giving a person a statin who is going to be vulnerable and might get this disease if they're given a statin. And we'd love to be able to prevent it from happening by identifying those that are susceptible. In terms of treatments, now I'm going back to both anti-SRP and anti-HMGCR. So there's a variety of medications that we kind of use for all different types of myositis. So steroids like prednisone often tend to be one of the first drugs that people are treated with who have one of these diseases. And then we have a bunch of medications that can be taken by mouth that suppress the immune system. Methotrexate, azathioprine, which it sounds like was the first one you were on, Colleen, followed by mycophenolate, which is another name for Cellcept, and then tacrolimus is another one. And I think, Colleen's story highlights that we don't know as physicians which of these are going to work for you. So Colleen didn't respond well to azathioprine, responded well to mycophenolate. There are other anti-SRP patients who might not respond to mycophenolate, but respond to azathioprine. So another really big area of research is trying to understand who's going to respond to what drug. I don't know your whole story, Colleen, whether you ever needed any kind of infusible medications. A lot of patients with necrotizing myositis wind up requiring some type of infusible medication. One is intravenous immunoglobulin or IVIG, and another one is rituximab. IVIG is a medication often given like once a month to patients with myositis, whereas rituximab is an infusible medication often given every 6 months, sometimes in divided, and then 2 doses close together, and then 6 months later getting it close together again. We have learned something about these drugs and which ones are good for what. So it turns out that IVIG seems to be particularly good for patients who have anti-HMGCR myopathy. So in one instance, we took 3 patients who had anti-HMGCR myopathy, not treated with anything else. And these guys, women, I call them guys, these women were really uninterested in taking steroids because they knew about the side effects. They already had diabetes. They didn't want to make that worse with steroids. So we treated them with IVIG alone. We call it monotherapy because it's just like the only drug that we treated them with. And again, these are slides kind of meant for doctors, but I'm hoping I can just explain to you that after a short time, after just like a few months, their muscle enzyme levels, their CK levels dropped dramatically, and they got a lot stronger. And that improvement continued for months or years. And so we really do like IVIG, if not at the very beginning. We often use it very early in patients with anti-HMGCR myopathy. And this is just another paper that recently came out from my colleague Rohit Agarwal at University of Pittsburgh, where they showed that IVIG is really good in necrotizing autoimmune myopathy. And their study included mostly anti-HMGCR positive myopathy patients and also a few anti-SRP patients who benefited. And basically these graphs just show what their CK levels were before getting IVIG, and shows how they dropped pretty dramatically after 3 months of treatment, and then came down even more after 6 months. And this is showing their strength going up, which is good, improving after getting the IVIG. So we do like IVIG for myositis, and particularly necrotizing myositis. In our view, and in others, we think that we like to use IVIG early in anti-HMGCR myopathy. And I'm not going to show you all the data for this, but most of us who see a lot of patients like yourselves who have HMGCR and SRP, we think rituximab works particularly well for anti-SRP myopathy. And when I see a patient in my clinic who has anti-SRP myopathy and they're having trouble walking or swallowing, I'm like rituximab right away. Other people might wait longer, but these are treatment guidelines that have been recently published. They were developed by an international consensus of physicians. It's not clinical trial level data. It's not like the best level data, but based on our collective experience, again, we think IVIG works really well for patients with anti-HMGCR, and rituximab really well for anti-SRP. So another way, we treat them a little bit differently. What do we do? Some of you out there with anti-HMGCR myopathy have it because you got put on a statin and you had to come off the statin, but you still have the high cholesterol. So what can we do for you to manage your cardiovascular risk? Well, I think I already said you can't put somebody back on a statin, but the good news is there's a new class of cholesterol lowering agents They're called PCSK9 inhibitors. So one you might have heard of is called Repatha. And these are injectable medications. You have to get insurance approval for them. But from what we can tell, these PCSK9 inhibitors are really good at reducing cholesterol levels in our anti-HMGCR patients and do not cause flare of the disease. So we do have ways of managing cholesterol levels, particularly in patients who've already had a heart attack or a stroke or something like that, and not exposing them to risk of having their disease flare. This gets back to your comment, Rachel, about the young person who had necrotizing myositis. And this is another case I just wanted to, tell you about, because I think it illustrates the important point that this is not just for adults. So we saw a kid who was 13 years old, who was a really good athlete until he was about 10. And then he started getting weaker, and he actually started, instead of getting to be a faster runner, he was getting slower until his mom could really outrun him. And they knew that just wasn't right because he was super strong. And he just got worse over a few years. He went to see his physician, and he had a CK that was 8,000, weak arms, weak legs, a muscle biopsy that they thought looked like genetic muscle disease. And he was diagnosed with a type of genetic muscle disease called limb-girdle muscular dystrophy, based on his slow progression, that he was a kid, and that his muscle biopsy sort of looked like that. But when they looked for genes that caused limb-girdle muscular dystrophy, he was normal. They couldn't find any. And we saw him here at the National Institutes of Health, and we recommended that he get anti-HMGCR and anti-SRP testing. And he was positive for anti-HMGCR autoantibodies. He was the first child we had seen with anti-HMGCR. And when we did a physical exam, he was really weak. So he couldn't raise his legs off the bed. If he was like lying down in bed, he couldn't raise his legs off. He couldn't lift his head off the bed. He was on the verge of needing a wheelchair. And we decided to treat him with IVIG. And he came back 3 months later, and his CK had dropped from 8,000 to 400, and he was totally strong as far as we could tell. He's one of our best responders. And this is a MRI imaging of his muscle. I'm not going to go again through this in super detail, but you see, this is like a cross section through his thighs. So this is his right thigh, this is his left thigh, this is the quadriceps muscle, these are his hamstring muscles, and the white means muscle fibers are dying or inflamed somehow. And after 3 months of IVIG, you can see they're black, which is normal. So this is a kid who responded really well to IVIG once we recognized that that's what he had. So we're really trying to get the word out that and we've actually shown this in another publication, that there are a surprising number of kids and young adults who are walking around with a diagnosis of muscular dystrophy, which is untreatable, who actually have necrotizing myositis and aren't getting treated properly. So we're really trying to get the word out that these are diseases that affect not just adults, but also can affect children as well. And we, in patients who have high CKs, kids who have high CKs and muscle weakness like this, we really think it makes sense to do the testing, to do the antibody testing, to make sure you're not missing a treatable disease. That case emphasizes that we can be really successful at treating necrotizing myositis, but as I'm sure many of you know, that's not always the case. And so we've looked at our anti-HMGCR and anti-SRP patients, what happens to them over time as we treat them, how many get better, how many stay the same, how many get worse. And so this is a paper from a few years ago where we had 50 patients with anti-HMGCR myopathy and who were followed for at least 2 years in our clinic. Out of these 50, only 22 got back to full strength. And the age of the patients, the average age of the patients who got better was 56 years old. Out of these, and this is another point, out of the 22 who reached full strength, only 3 of them could we get off of medication. which really emphasizes that even in those people who respond well, currently it's a chronic disease that requires chronic immunosuppressive therapy, not always, but often. And also, even among the 22 reach full strength, 12 of these, more than half, still had high CK levels. Meaning, even though their strength was good, we know that there's still some disease activity going on that we're not effectively managing. And then out of the 50, 15 really stayed pretty weak with higher CK levels over 1,000. And of those who got weaker or stayed weak, the average age was lower, 48, which again emphasizes that the younger patients on average don't do as well as the older patients. And it's kind of the same story with anti-SRP. I won't go through the whole thing, but I guess, that I wanted to end with that, because I think it really emphasizes that although we have a lot of success stories, we also have stories of people who aren't doing well, who are continuing to get weaker despite aggressive therapy. And we really need better treatments for patients with necrotizing myositis, especially our younger anti-SRP and anti-Hmgcr patients. They can be among the most difficult to control. And currently, even despite being super aggressive, sometimes we're not totally effective at treating them. And it's terrible for our patients, and we feel terrible about it. So, one of our priorities is to try to develop more effective treatments for patients like yourselves, and especially those who aren't doing as well. So I think I'll end my. I think I will stop the share there, and I hope that was somewhat helpful for people. I know the slides were kind of oriented towards a MD type of audience, but I hope I was able to, at least in words, explain where things stand with our understanding.
We have more questions for you in a minute, but first I just wanted to see, Colleen, did you have any questions for Dr. Mammen, or Dr. Mammen, did you have questions for Colleen?
Yeah, so Colleen, I have to apologize because I didn't see your full presentation because I was trying to get my own stuff together here, but when were you at your weakest?
I was probably at my weakest.
Can you speak closer to your microphone?
Sure. Better? Is that better?
A little bit.
Better.
Okay. I was probably at my okay, great. Probably at my weakest. I remember being in the hospital for the muscle biopsy, and the neurologist who saw me said, "Can you get yourself off the floor if you fall?" And I said, "Yes." And he said, "I don't believe you. Let me see." and indeed, he was correct, and I could not get myself up off the floor. The azathioprine worked really, really well at first. And then after a couple years, I was probably even a little bit weaker than even initially. And the mycophenolate made a huge difference. I have not been able to be tapered off. I did get down to a dosage of 1,000 milligrams a day. And now we've had to go back up because my CK is, I actually got my CK to the point where it was just about within normal limits, and it started to rise again. And I'm due to come back shortly and get my labs repeated. So we'll see what we're going to do next. But the mycophenolate has been probably the best therapy. I did also start on high dose steroids, and I empathize. That's a tough one. I think I spent initially at the time of diagnosis 10 years ago, I think I spent about 8 months at 80 milligrams a day and then being tapered down.
Yeah. So, and I would say, and I saw you nodding when I was talking about infusible medication. Did you ever try any of those?
I have not tried. It is on the table for discussion. I do really enjoy my work. That may have to be tabled for a little bit if we add an infusible in.
Yeah, well, rituximab shouldn't interfere too much, and it's what we think is probably. Again, I can't really offer you advice. I'm just
Yeah, no,
You know,
understood.
but in
You
general,
peek at that file. You peek at that file and tell me.
or you can send me an email saying that. But if you know, my general advice to anti-SRP patients, if they're going to choose which infusible medication to try, most of us would go for rituximab,
Right.
unless there's some reason not to do it. And the only issue with rituximab is that it takes a while to work. So if you give somebody rituximab, you don't expect to see a response for like 8 weeks or so. But one of the reasons patients seem to like it better is because, again, it's only every 6 months as opposed to like 5 days a week every month or something like that.
The statistics are impressive. They're impressive. And as I look at that, I do think I'm kind of hitting a plateau with my strength. For a while when we went up on the CellCept, I was getting a little bit stronger, and now I definitely see where it's kind of leveling off, and the statistics are impressive.
The other thing,
That's good.
the other thing
Go
that,
ahead.
oh, I was going to say that I didn't really mention that I think that's important to understand is that for necrotizing myositis, if the disease is left suboptimally treated, you can develop replacement of the muscle tissue by scar tissue.
Mm-hmm.
And when that happens, you can't make patients stronger.
Right.
Like if the muscle has been replaced by scar tissue, you can't make muscle come back. And so we tend to be pretty aggressive about trying to get the CK as close to normal as possible, because we worry that if we let it run high, that there's going to be damage to the muscle that we can't reverse. So I always urge people to kind of jump on the treatment. And doesn't just apply to you, but just a thought.
Well, thank you so much.
Let's for discussion. Sure.
We need to move on to Q&A, and you went right into it because we may have some newly diagnosed people, and I'd like to know what is normal for CK. I hear a lot of numbers thrown around, but I don't know what is a healthy amount of CK.
So it varies by race and gender, and so there is some variability. For white patients, for men, probably under 300 is normal, and for women is probably under 200 is normal. For African American patients, there's a broader range because about 1 to 2% of just healthy African male men are going to have a CK of just under 1,000. But I would say most people don't know their baseline CK, meaning what their CK was before they got myositis. So it's hard. It can be a little bit hard to know depending on your race and gender. So you have to take that into account. But for most patients, it's going to be under 500. And for many, it's going to be under 300.
Okay, thank you.
That's
I've got a couple of questions that were emailed in. Should a patient diagnosed with classic dermatomyositis be assessed for NM if they have lost a massive amount of muscle tissue and strength?
So what I can say is that there are a very small number of patients who appear to have both dermatomyositis and necrotizing myositis. So I would say if there's something that raises the suspicion of having a necrotizing myositis, it's pretty easy to check those two antibodies, SRP and HMGCR. You'd be the rarest of the rare if you had dermatomyositis and those were positive, but it might help to explain why you have so much muscle loss. That being said, some people with dermatomyositis just have a lot of muscle loss.
Okay. With necrotizing myositis, you talk about the cells dying. Does that mean, but then I also heard you say something about inflammation. So the cells can still be inflamed even though they're dying. How does that work?
Yeah, so so the idea is in the necrotizing myositis, what it seems that the main process in the muscle is the muscle cells breaking apart and dying, and we don't know why that is. In the other types of myositis, there are white blood cells that seem to come in from the blood and invade the muscle and may be involved in causing the muscle damage. And so that would be inflammation. We call it inflammatory muscle tissue. That being said, some patients with necrotizing myopathy also have inflammatory cells coming in and invading the muscle, but we don't know whether they're causing muscle damage or they're actually helping with the muscle repair process. So it's complicated, but at the end of the day, if you have like anti-SRP or anti-HMGCR antibodies, it kind of doesn't really matter what the fine details are of the muscle biopsy. You have like an autoimmune muscle disease that we understand those as separate types of muscle diseases. I hope I answered that question.
Let's move to the Q&A box and see what we have in there. And we will try to get to as many of them as we can. We had somebody wondering if necrotizing and polymyositis is the same. And one of the email questions that came in says that, you know, she's got a diagnosis of NM, but her neurologist is treating her with IVIG for PM. And so,
yeah, so this is, it gets into just sort of naming wars or whatever. So there's a couple, it's complicated. So the first I would say is that currently, most of us don't really think of polymyositis as a separate disease category. Patients with necrotizing myositis would have 20 years ago been called polymyositis. Many patients with inclusion body myositis would have been misdiagnosed as polymyositis. Some of the anti-synthetase patients with no rash would have been called polymyositis. But now, instead of now we've divided polymyositis up into like several different diseases. So we recognize that necrotizing myositis is its own type of myositis that's different than inclusion body myositis, that's different than the anti-synthetase syndrome without a rash. Insurance companies have not caught up with this. And so even though I might diagnose you with necrotizing myositis, when I am coding you and telling the insurance company why I want to give IVIG, I may be calling you polymyositis.
right.
Because
So-
they'll give you they might approve IVIG for polymyositis, but they have no idea what necrotizing myositis is because they just haven't caught up. So
basically worry less about what it's called and how you're responding to the treatment.
Well, it is important to get the correct diagnosis because we treat necrotizing myositis different than the anti-synthetase syndrome or inclusion body myositis. So you do want the appropriate diagnosis. And when somebody tells me that the diagnosis is polymyositis, I actually just don't know what that means. On the other hand, I wouldn't worry so much about what they're calling it when they are trying to get approval for medications, because they may be thinking about how insurance companies think about it. But as a physician, I want to know what antibody you have, and that tells me, or whether you don't have an antibody, and that allows me to tell you what to expect from your disease and what treatment we ought to do. Whereas polymyositis doesn't tell me anything. And even within necrotizing myositis, it's really important for me to know, are you SRP or are you HMGCR? Because for like Colleen, I would say SRP, let's go with rituximab. If she told me I've got HMGCR, I might say, I think the chances are you're going to do better with IVIG. So it is important to know, but it can be complicated about how it's reported out to insurance companies.
Right. So it sounds like a conversation is in order with your medical professional.
Very true.
And I do want to point out that the Myositis Association has a new feature on its website called Metafind, and it will give you a list of doctors in your area that has experience treating myositis. And so if you are looking for a second opinion or someone with more experience than your current physician, you can always use that feature. It is under myositis.org, and then you go to patient support, find a doctor. Okay, let's go to another question.
Carol, can I put in a plug for the
Of course.
Yeah, so we are also happy to see any and all myositis patients at the National Institutes of Health. So, and that is not a charge thing. You have to agree to be part of our research protocol, which means we collect your clinical information and blood samples and so on. But at no, at no charge to you, we are happy to see just about anybody who's willing to come. And I can provide you guys with information about how to contact our research if anybody wants to come and participate. And as part of what we do, we gives like second opinions about diagnosis and treatment. The primary goal for us is to do research and understand these diseases better, but the thing that you might get out of it is a second opinion about the diagnosis and treatment strategy. So that's my little plug for it.
Do you have to be local or can they do it via telehealth?
You have to come to the NIH, but you don't have to be local, and we put people up in hotels and things like that. Usually we require people to pay transportation costs to get here, which I know can be substantial, but we'll usually put people up once they're here.
Okay, I am going to, I was going to put my email in the chat, but it seems like it's limited to hosts and panelists, so not everybody could see it. But my email is rachel@myositis.org, RACHEL@myositis.org. And if you want to take Dr. Mammen up on his offer, you can email me and I will get you the information.
And I'm happy to give you my my email. You can just email me directly. It's my name, which is just andrew.mammen at nih.gov. And so it's pretty simple. I'm easy to find.
Andrew.mammen@nih.gov.
Yep.
All right. Okay. I tried to be a buffer.
No. And
you don't need a buffer.
If you look hard, you'll find my cell phone number too.
Oh no.
But I won't give that to everybody, but if you guys are savvy, I know you'll find it. But the best way is to email me, because then I can connect you with our research.
Right. Okay. Let's see. If the anti-Hmgcr NAM is caused by the body attacking cells that create cholesterol, would this cause low LDL and HDL?
So it's complicated, but not as far as we know.
Okay.
If only having this disease lowered your cholesterol, but it doesn't.
Right, that would be a bright spot. I'm gonna get you a T-shirt that says it's complicated.
Yeah.
I think that's the third time I've heard it, but it's true. A lot of these questions you can't answer in black and white. Okay. Do NAM patients also tend to have higher than normal troponin? I don't know if I'm saying that right.
Oh, troponin.
Troponin.
Okay, so this is that's an important question. So troponin is a enzyme that lives in not just skeletal muscle, but also, well, there's two types of troponin. There's troponin I and troponin C. And troponin C lives in both skeletal muscle and cardiac muscle. So when you're troponin, people used to check for troponin C to see whether you're having a heart attack, like is your heart muscle being damaged? And so if you had a high troponin C level, everybody got all excited that you're having a heart attack. But troponin C, myositis patients have high levels of troponin C because it's being released from their damaged skeletal muscle. Troponin I is only released from damaged heart muscle. So many labs now will just check troponin I when they're trying to decide whether a patient is having heart damage. And if your troponin I is high, then it means you're having heart damage. Whereas if your troponin C is damaged, it could be that you're having a heart attack, but it could also be that you're just a myositis patient. So occasionally we do have patients with myositis who go to the emergency room for one reason or another, and emergency rooms are always checking people's troponins. And if they check the troponin C and it's high, everybody gets into a big, starts to panic that the patient's having a heart attack. But if you check the troponin I, it's normal. So troponin C, yes, can be elevated in patients with myositis, but not troponin I, unless they happen to also be having a heart attack. So it's a little bit long-winded answer, but I hope that helps to clarify it a little bit.
Mm-hmm. What are the alternatives to steroids for people who have mental health issues, since there's a really bad interaction?
Yeah, so that's absolutely true. People can have all kinds of different reactions Some people get depressed on steroids, and some people get manic on steroids, and everybody gets irritable and has a hard time sleeping with steroids, just about. And often it's like the spouse and family members who really want the patient to lower the steroid dose because of that. So in general, we try to, although we might start with high dose steroids at the very beginning of disease, we really want to lower the dose of steroids as quickly as possible to limit these types of side effects. And so that's why these other medications like Cellcept, azathioprine, IVIG, and rituximab are so important, because even if you have let's say you're an SRP patient, you have a great response to high dose steroids, that's just not a good long-term solution. And so those other medications that I mentioned are designed to use to spare the amount of steroids that people are going to need. And so a lot of my HMGCR patients, I never ever treat with steroids. I just treat with IVIG. SRP is not so simple.
Okay, I've got a question. And we're getting close to time here. Do you have a few more minutes?
Yeah, I'm good.
Okay. My MD, who is treating me for my NAM and mitochondrial dysfunction, as well as my neurologist, say that my NAM is because of my long-term use of HIV meds, 28 years. My neuro says in order for me to get better, I have to stop my HIV meds, but my HIV MD says no, and that I also need to stop the high dose of prednisone. Do you have any thoughts? I know without seeing the file, it's hard to know, but.
Okay, I'm going to need 2 of those. It's complicated T-shirts for this case. I don't think I can give you a good answer. I'd be happy to talk to you more by email. You could come see us. But when you have HIV and myositis, we've seen a number of patients with both of these. Then it gets really, and then it gets it gets to be a little bit complicated. We need to. I've never seen a NAM patient who had HIV. We see a lot of HIV patients who actually have inclusion body myositis. In terms of when we examine them, we can tell they have inclusion body myositis. So I don't want to say that you do or don't have NAM, but it makes me suspicious. Like I'd really want to confirm that you really do have HMGCR anti-SRP antibodies, and that you don't.
Yeah, this is a person within another question said that their doctor is not doing all of these tests that you're talking about. So,
Yeah.
So definitely, if they want to do the tests that you need, I would look into getting a second opinion.
Yeah, I don't know. Maybe you can point them, Rachel, in a good direction in terms of where they live, who it might be good for them.
Yeah.
But HIV, only we've seen maybe 20. We have 3,000 or 4,000 myositis patients at the Hopkins cohort, and probably only 20, 25 have HIV. And so it's like the rare of the rare, but we do know a certain amount about them and how to treat them. But you really need to see somebody with a lot of expertise in that type of situation. And then also, of course, there has to be a dialogue between who's ever immunosuppressing you and who's ever treating the HIV, because you got to make sure that you don't unleash HIV disease, right? You got to make sure that if you're going to suppress the immune system in somebody who's already immunosuppressed, or to stop one of these medications, there's a lot of nuance involved, and I can't really give specific.
Right.
Yeah.
Right. I understand. How often should a CK be drawn?
Depends on whether it's early in the disease, when things are unstable and you're trying to gauge response to treatment. If you're changing the treatments often, in those situations, you're checking the CK pretty often. If you've had anti-SRP for 10 years and your CK has been 400 to 800 or whatever the last year or two that's been checked, you're not changing the medications, you don't need to check it as often. So there's no one size fits all answer to that question. I would say on average, I'm checking the CKs of my patients about once per month.
Okay. I want to take this time. Thank you so much for being here. Stay on if you can, but I wanted to take this time to talk to someone else who lives with necrotizing autoimmune myopathy. Karen, are you still on the line? If you could unmute.
Hi, yes, I am.
Hi, Karen. How are
Hi.
you?
Okay, great. How are you?
I'm doing good. Could you briefly just talk about like what was your worst moments with the disease and what has been your recent accomplishment? I know it,
Sure.
but I want to leave on a high note here.
Right, great.
So go
Sure.
ahead.
Back in 2019, it was now I was a very healthy individual, no health issues whatsoever, good weight, active, running marathons. And then in July of 2019, I I thought it was great. I was losing some weight, but then all of a sudden I started losing like 30 pounds a month, started falling, fell off the treadmill, fell at work. And they did run all the blood work that you suggested, but nothing was showing up except the elevated CK levels. They were up at 14,000. But then from that point, they did the muscular dystrophy, Parkinson's, you name it, they did it. And then finally, just one day in September, they put me in the hospital. And it took doing two biopsies for them to come up with the diagnosis of necrotizing autoimmune myositis. They don't know which version I have because I was a perfectly healthy individual. But my worst moment is I couldn't raise my legs, couldn't raise my neck. I had dysphagia. I still have a little bit of it, but I couldn't speak, couldn't move my hands, arms, neck. I literally had to be picked up and moved from the bed. Then after the diagnosis, they put me on high dose of prednisone because at that point I got down to 89 pounds. He said the main concern is I had to put weight on. But magically, a couple weeks later, I was able to be moved to an acute rehab center where I learned to walk, talk. Still couldn't eat yet. They had a peg tube in me. But I had to learn all the basic functions all over again.
That sounds
But
really difficult. And but let's
Mhm.
talk about I'm
Oh yeah,
5 minutes over. So
okay.
what news do you have for us now?
Okay. Almost 3 years out of it. My CK level is 123, and I have completed 2 5K marathons.
That is amazing.
So I came in third.
You
This
came in
time for my age,
third. That is
for my age group.
amazing.
Fantastic.
For my age group.
That's amazing, Karen.
Yep. So
Yeah.
it wasn't going to I wasn't going to let it define me. I mean, I'm
Right.
not 100%, but you know what? I'll take what I have, as you say, the new normal.
Right. Well, thank you so much for being
Sure.
on with us, Karen. We
Sure.
appreciate it.
Thank you.
And Colleen, thank you too for being
you.
on with us. We appreciate you sharing your story. And Dr. Mammen, thank you again for all that you do. And I just want to say to everyone, tune in this Thursday. We have our Ask the Doc, and that will be with rheumatologist Dr. Floran C. Ernst. And it will be this Thursday at 6 p.m. EST. So we hope you can join us. So for TMA, I'm Rachel Bromley. Good afternoon.
Hi, guys.
You. Bye.
Bye.